the first topic like that we will be starting is the connective tissue disorders. And what are all the topics that I'll be revising in the connective tissue disorders are like these are all the topics like vasculitis, systemic lupus erythematosus. And in vasculitis, I'll try to cover all the types of vasculitis, that is large, medium, and as well as small vessel vasculitis, rheumatoid arthritis, ankylosing spondylitis, Behcet's, reactive arthritis, Sjogren syndrome, Scleroderma, then gouts, and then Apla syndrome. So these are all the topics like that we'll be covering in the today's rapid revision of the connective tissue disorders. So the first topic that we'll be starting is, so if you see this question, which of the following is not a large vessel vasculitis? The options are giant cell arteritis, Takayasu arteritis, idiopathic cutaneous vasculitis, and Behcet syndrome. So anyone want to make an attempt of this question? Right. So if you see this question, it is the idiopathic cutaneous vasculitis. Very good, Monica. So it is idiopathic cutaneous vasculitis, which is the small vessel vasculitis. Now let me just tell you the examples of all the forms of vasculitis. Now you take the large vessel vasculitis. The examples of the large vessel vasculitis, that includes Takayasu arteritis, and then the giant cell arteritis, and then Behcet's. But if you take these Behcet's, it can be both. It is either medium vessel vasculitis or large vessel vasculitis. Then followed by that, we have the medium vessel vasculitis. The examples of medium vessel vasculitis, they include Polyarteritis Nodosa. Then followed by that, we have the Wegener's granulomatosis. Then the Berger's disease. Right? And this particular, I'm very sorry, one second. So Polyarteritis Nodosa, Berger's, which is also called thromboangiitis obliterans, and then Kawasaki disease, right? And what are the examples of the small vessel vasculitis? The examples of the small vessel vasculitis, that includes Wegener's granulomatosis, then Churg-Strauss Syndrome, next microscopic polyangiitis, and then the Henoch-Schonlein Purpura. So this is how we classify the vasculitis depending upon the vessels which are being involved. Now you also need to know what is the most common vasculitis in children. So please remember, the most common cause of vasculitis in children will be Henoch-Schonlein Purpura. It is not your Kawasaki disease. But this Henoch-Schonlein Purpura is not only seen in children, it is also seen in adults. And what is the second most common cause of vasculitis in children? That will be your Kawasaki disease. But this Kawasaki, let me tell you, it is most commonly seen in children, very rarely, hardly like 1 to 5% you see that in adults, but most commonly it is seen in children. Which one? The Kawasaki disease. Now you need to know what is the most common cause of vasculitis in adults. The most common cause of vasculitis in adults, that will be idiopathic cutaneous vasculitis, right? This will be the most common cause, idiopathic cutaneous vasculitis, right? So this will be the most common cause of vasculitis in adults, right? It is not your giant cell arteritis, it is your idiopathic cutaneous vasculitis. Then followed by that, we have the giant cell arteritis. Okay, now the other way by which the vasculitis can be classified is based on the type of inflammation. So in certain vasculitis you have granulomatous inflammation, and in some you have the non-granulomatous inflammation. Now what is that vasculitis where you have granulomatous inflammation is, that is giant cell arteritis, Takayasu arteritis, then Wegener's granulomatosis, which is a small vessel vasculitis, then Churg-Strauss syndrome. These are all the vasculitis where you have granuloma formation, right? What is that you have non-granulomatous? What are the conditions where you have non-granulomatous vasculitis that you come across in patients with Polyarteritis Nodosa, then Kawasaki disease, next microscopic polyangiitis, and then Henoch-Schonlein Purpura. So these are all the conditions where you will have the non-granulomatous vasculitis. Now, in case of vasculitis, the another important classification is the type of the antibody, right? So just 1 minute. Right. So you should be aware of the antibody. Okay. So we have P ANCA and as well as the C ANCA. So these two are the antibodies. So what exactly is your ANCA? That is anti-neutrophilic cytoplasmic antibody. Now, where exactly is the target antigen of the P ANCA? So P ANCA and C ANCA are antibodies. Antibodies means they have to be formed against a target antigen. So the target antigen for your P ANCA, the word P stands for perinuclear region. And what is the target antigen there? It is myeloperoxidase. Whereas you take C ANCA, The localization of the target antigen in case of C. anca, the word C stands for the cytoplasm, right? The word C stands for cytoplasm. Now, what is the target antigen for the C. anca? That is proteinase 3, right? That is proteinase 3. So myeloperoxidase for your P. anca, and for C. anca, it is the proteinase 3. Now, what are the associated conditions? You take C. anca, you see this only in one condition, that is Wegener's granulomatosis. But P. anca, it is present in multiple forms of vasculitis. That is in case of microscopic polyangiitis, which is a small vessel vasculitis. Then Churg-Strauss syndrome, which is also a small vessel vasculitis. And apart from that, even in case of idiopathic crescentic glomerulonephritis also, you have this P. anca being positive. Now, these are the various ways by which you can classify the vasculitis based on the size of the vessel, based on the type of the inflammation, based on the antibodies. Now, followed by that, let us try to discuss the individual forms of the vasculitis. So, if you see this question, a 24-year-old female presents with the abdominal pain, hematuria, and as well as the arthralgia. On examination, palpable purpuric rash was seen on trunk, limbs, and as well as buttocks. The coagulation tests were normal. What is the most probable diagnosis in this patient? The options are hemolytic uremic syndrome, Henoch-Schonlein Purpura, meningococcemia, thrombotic thrombocytopenic purpura. Now, so if you classically observe here, like the individual is having abdominal pain, hematuria, arthralgia, and then palpable purpura is there. So all these are suggestive of the Henoch-Schonlein Purpura, that is HSP. Now HSP, let me discuss that in detail. It is a form of the small vessel vasculitis, and this HSP is characterized by a triad. Now the another name for your Henoch-Schonlein Purpura is, this is also called as anaphylactoid, right? This is also called as the anaphylactoid purpura. Now, what is the tetrad in case of the Henoch-Schonlein Purpura? What did I tell you? It is the most common cause of vasculitis in children, but it can also occur in adults. Now, the word H in case of the HSP stands for the hematuria, right? The word S stands for skin involvement. And what will be that skin involvement? That is palpable purpura, right? Palpable purpura. And the word P stands for pain, right? So where exactly you can have the pain? That is pain within the joints and as well as pain within the abdomen. So these are the four important manifestations: hematuria, palpable purpura, pain in the joints, and as well as pain in the abdomen. Now in these anaphylactoid purpura, what is the antibody, right? The most common class of antibody which is being deposited in the immune complexes is the IgA, right? So in the immune complexes, what you have is IgA. Now, when you are having this purpura, don't anticipate that the patient might be having thrombocytopenia. No, right? So these patients, they'll have normal platelet count, right? In fact, there may be even thrombocytosis also. Then why is this particular purpura? The purpura is mainly because of the cutaneous vasculitis. That is the reason why you have this palpable purpura. Now, what is the investigation of choice in case of the Henoch-Schonlein purpura? That is the skin biopsy. Now, what does the skin biopsy show in case of Henoch-Schonlein purpura? That will show you the presence of leukocytoclastic vasculitis, right? Leukocytoclastic vasculitis. That is the investigation of choice in case of Henoch-Schonlein purpura. Then what is the drug of choice in case of Henoch-Schonlein purpura? That will be the steroid, that is the prednisolone is being given. Now whenever you are talking about the pain within the joints, let me tell you which particular joints are commonly affected here. So it is mainly the joints of the lower limbs, right? That two large joints of the lower limbs are commonly affected in case of the Henoch-Schonlein purpura, right? Whereas if you take in case of rheumatoid arthritis, it is the small joints of the upper limbs which are commonly affected in case of the rheumatoid arthritis. Okay. So the drug of choice is your prednisolone, and the dosage of the prednisolone, it is around 1 to 2 milligrams per kg per day, right? And this prednisolone you have to give for a longer period of time, and later you can taper the prednisolone. But the only point is, whenever the individual is having like severe form of disease where the individual is unable to tolerate the prednisolone, then what are the alternative therapies? The alternative therapies what we have is rituximab and as well as the plasma exchange. Now, by doing plasma exchange, what is the advantage is that the immune complexes containing that IgA will be taken out by your plasma exchange. And what is the other alternative drug in case of severe form of the disease? that is your rituximab. Next to the prednisolone, the next important drug will be the rituximab. And yes, so this is the palpable purpura, right? This is the palpable purpura, and you have to understand the distribution of this palpable purpura. So most commonly, this palpable purpura, they are being distributed over the buttocks and as well as the lower limbs. This will be the distribution of the palpable purpura, right? So with this, we are done with one form of small vessel vasculitis, that is Henoch-Schonlein Purpura. Now, once we are done with the HSP, right, next let me take up the discussion of the Kawasaki disease. Kawasaki, what did I tell you? It is the medium vessel vasculitis. Which one of the following is the treatment of choice in case of Kawasaki disease? Cyclosporin, dapsone, intravenous immunoglobulin, methotrexate. Yes, very good. So, the drug of choice for Kawasaki disease, it is the intravenous immunoglobulin. Now, this Kawasaki disease is that like which is very commonly seen in children, right? So I'll just tell you the mnemonic for this Kawasaki disease. So we are very much aware that the children, they like usually the cream biscuits and all, right? So just remember this particular mnemonic, that is cream. So the very important point in case of Kawasaki is the fever, and this particular fever, it should be there for more than or equal to 5 days. Along with fever, just remember this cream. The word C stands for conjunctivitis, and this word is very important, non-exudative conjunctivitis. So in the recent past, a question has been asked, which among the following is not the feature of the Kawasaki disease, right? There was a clinical scenario, and which among the following is not the feature of the clinical scenario. One of the option was exudative conjunctivitis, right? So now if you just remember only conjunctivitis, there is high chance that you may land up in trap. So you have to remember very clearly it as non-exudative conjunctivitis. Then even rash also, it is not monomorphic rash, it is polymorphous rash. That means this particular rash which is present in various parts of our body and variable shapes as well. And all over the body, there will be edema within the individual and adenopathy. That cervical lymphadenopathy is very important. And that too, it is not symmetrical cervical lymphadenopathy, it is unilateral. This is very another important point. So it is not symmetrical, it is unilateral cervical lymphadenopathy. Okay. And mucosal involvement will be there, that is in the form of erythema or fissuring or crusting. So, right. So this is the image of the individual with the Kawasaki disease. So fever should be definitely there, and non-exudative conjunctivitis, then the cervical lymphadenopathy, rash, that is polymorphous rash, then the presence of edema, and then the mucosal involvement, right? And then mucosal involvement. Now, if you see the treatment in acute stage, we give intravenous immunoglobulin along with aspirin. But in case of convalescent stage, when the disease severity is reducing, the intravenous immunoglobulin will stop, and then we give only the aspirin at a dosage of 3 to 5 milligrams per kg once daily orally until 6 to 8 weeks illness onset. So that is during the convalescent phase. Now, this mucosal involvement is very important. That is, in case of Kawasaki disease, like you have what is called a strawberry tongue, right? So this is how the strawberry tongue doesn't look like. This is an animated image, right? But what you have to remember is that strawberry tongue is one of the important manifestation in patients with the Kawasaki disease. Now, I just want to ask you a quick question, that in Kawasaki, what type of strawberry tongue you will have? So is it like a red strawberry tongue, or is it the white strawberry tongue? So what is that you will have in case of the Kawasaki disease? Okay, so you take this Kawasaki disease, the strawberry tongue that you will have is the white strawberry tongue. Then what is the condition where you will have the red strawberry tongue? The red strawberry tongue, you will have that in case of the scarlet fever. It is seen in case of the scarlet fever. And there are many strawberries, and this is like one of the fancy questions which is being asked in the recent past, right? So these are all the strawberries in medicine, and we have few more strawberries. I'll just discuss about them. Now you take the strawberry nose. So strawberry nose, it is present in rhinosporidiosis, right? Whereas the strawberry gingiva, it is present in the Wegener's granulomatosis or granulomatosis with angiitis. Then strawberry cervix, it is present in the Trichomonas vaginalis. And strawberry gallbladder, it is present in cholesterolosis. Okay, so these are some of the strawberries, and apart from that, we have few more strawberries. What are all those? So strawberry tongue, we have discussed, that is Kawasaki and as well as scarlet. Then strawberry gingiva, I have said you, that is Wegener's. Strawberry nasal mucosa, right? This is an add-on point that is seen in patients with the sarcoidosis. Strawberry nose, we have discussed, that is rhinosporidiosis. Strawberry gallbladder cholesterolosis, that also we have discussed. But strawberry shaped skull, right? You can see that the strawberry shaped skull that you come across this in case of the Edwards syndrome. And where is that you have the strawberry nevus, that is in case of the capillary hemangioma. Strawberry vagina we have just discussed, or strawberry vagina or strawberry cervix, and strawberry lesion of rectosigmoid junction, that is seen in infection of the spirochetes or the bacillus. So these are all the strawberries like what we come across in medicine, right? So having discussed about we have discussed Henoch-Schonlein Purpura, we have discussed Kawasaki disease. Now we'll move on to the next important form of the vasculitis. So you see the clinical scenario: a 20-year-old woman presents with bilateral conductive deafness, palpable purpura on the legs, and there is hemoptysis. Radiograph of the chest shows thin walled cavity in the left lower zone, right? Thin walled cavity in the left lower zone. Investigation revealed the total leukocyte count of 12,000. I'm sorry. Total leukocyte count of 12,000 per cubic millimeter, and RBC cast is present in the urine, and serum creatinine is 3 milligrams. That means even there is elevation of your serum creatinine as well. So what do you think is the most likely diagnosis in this patient? HSP, polyarteritis nodosa, Wegener's granulomatosis, and then disseminated tuberculosis. So what do you think is the correct answer in this question? Right, very good, Himanshu. So this will be the Wegener's granulomatosis. So Wegener's granulomatosis, what exactly is this? It is a form of small vessel vasculitis, right? And you have the granuloma formation. The word itself tells you it's a granulomatous inflammation. And in case of your Wegener's granulomatosis, the antibody that will be positive is the C ANCA is being positive. Now, in case of Wegener's granulomatosis, you need to remember a triad of involvement. What is the triad which is involved in Wegener's? Upper respiratory tract, lower respiratory tract, and there is involvement of the kidney in case of the Wegener's granulomatosis. Now you take this, the upper respiratory tract involvement. So upper respiratory tract involvement will be in the form of like involvement of nose, involvement of ear, and as well as the involvement of throat and as well as mouth. Now what will be the nasal involvement? See, nasal involvement will be the septal perforation, right? And thereby there can be collapse of the mouth, sorry, collapse of the nose, and that will give you the characteristic saddle shaped nose. Right? And what will be the ear involvement? The ear involvement will be in the form of the conductive deafness, right? It is in the form of conductive deafness. And what will be the throat involvement? That is in the form of the strawberry gums. So that will be the upper respiratory tract involvement. Then followed by that lower respiratory tract involvement. So because of lower respiratory tract involvement, the patient can present with cough, hemoptysis, and as well as the dyspnea. And whenever you do a chest x-ray, there is a high chance that there can be a thin walled cyst or a cavity that can be seen within the lung involvement. Then followed by that, the kidney involvement. So kidney involvement, it is seen in almost 80% of individuals. And this particular kidney involvement, it is in the form of crescentic glomerulonephritis. Now, when do you call crescentic glomerulonephritis? That is, within the glomerulus, if you observe half moon shaped collection of the inflammatory cells, that is the point when we use the word crescentic glomerulonephritis. So these are the three important organs which are being affected in case of the Wegener's granulomatosis. Now out of all these, the most common will be the upper respiratory tract involvement, that is your either nose or ear or the throat and gum is being affected. That will be the most common involvement in case of the Wegener's granulomatosis. Then what do you think is the investigation of choice? Is your antibody, that is the C ANCA will be positive. Now what exactly is the drug of choice? So now the standard treatment for severe Wegener's granulomatosis is to induce the remission with immunosuppressant drug. And what is that particular immunosuppressant drug that we need to give is, so we need to give steroids, but only steroids will not suffice in this scenario. Along with steroids, you need to add rituximab or you need to add the cyclophosphamide. So that is what you have to give in case of the severe disease. Then the another important is the plasmapheresis. Plasmapheresis is sometimes recommended for very severe manifestations of Wegener's granulomatosis. Like whenever there is like diffuse alveolar hemorrhage or whenever there is rapidly progressive glomerulonephritis, that is the point when the patient may require, that is plasmapheresis. Okay, where they'll take out this antigen antibody complexes. So this is about your Wegener's granulomatosis, which is a small vessel vasculitis, right? Now, then you take the another clinical scenario, that is a young female, a patient presents with rhinitis not subsiding with antihistaminics, rhinitis not subsiding with antihistaminics, along with recurrent hemoptysis and glomerulonephritis. Now the point is, which of the following is not an important differential diagnosis that can be taken into this scenario? Behcet syndrome, Wegener's granulomatosis, microscopic polyangiitis, then polyarteritis nodosa. Now, the very important is in this patient, the patient is having kidney involvement and as well as lung involvement. So, in case of polyarteritis nodosa, there is no lung involvement, right? There will be never a lung involvement. So, the correct answer here is the polyarteritis nodosa. So, lungs are not involved in polyarteritis nodosa. Now, let me take up the discussion of the polyarteritis nodosa. So, polyarteritis nodosa, what did I tell you? It is a form of the medium vessel vasculitis. It is a form of the medium vessel vasculitis. Okay. Now, what will be the skin involvement or cutaneous manifestations in case of the polyarteritis nodosa is that they'll have libido reticularis. You see here. So, what exactly is your libido reticularis? That is the lacy distribution of the cutaneous blood vessels, mainly within the lower limbs or buttocks. That is what is called as the libido reticularis, right? And that will be the cutaneous manifestation. And the other cutaneous manifestations could be in the form of nodules, papules, and as well as even ulcer formation can also be there in case of the skin involvement. Now, then followed by the vasculitis of the peripheral nerve. So, because of the vasculitis of the peripheral nerve, the individual can develop what is called as mononeuritis multiplex. Right? The individual can develop what is called mononeuritis multiplex. Okay. Right. Next is the vasculitis of the gastrointestinal tract. So due to vasculitis of gastrointestinal tract, there can be abdominal pain. That is postprandial angina will be there. And why is that? That is because of mesenteric ischemia. Right? That is because of mesenteric ischemia. In the sense, there will be vasculitis of your celiac trunk or superior mesenteric artery or the inferior mesenteric artery. Okay. Right. And the other manifestations is there can be even gastrointestinal bleeding as well. Now, what is the associated viral infection? Right. What is the associated viral infection for the development of your polyarteritis nodosa? This is a very important question. That will be your hepatitis B. That will be hepatitis B. Then you need to know that there is also vasculitis of the kidney. That is called renal vasculitis. And because of this renal vasculitis, the individual will have decreased renal perfusion. Thereby, there is activation of RAS causing the hypertension. Okay. So, hypertension is mainly because of your renal vasculitis. Then even there is also the joint involvement. But which particular joints are involved? Again, it is the large joints of the lower limbs. Right, large joints of the lower limbs. And what are the cardiac manifestations in polyarteritis nodosa is that there can be development of the congestive heart failure and as well as the myocardial infarction. Then what will be the CNS manifestation? That will be in the form of the cerebrovascular accidents. That will be in the form of cerebrovascular accidents. Why is that? Because due to decreased perfusion of the blood to the brain. Then what does the biopsy show? See, biopsy in case of polyarteritis nodosa, that will show you that there is non-granulomatous inflammation. So where do you come across granulomatous inflammation? That is Wegener's, Takayasu, and as well as giant cell arteritis. But whereas in case of the polyarteritis nodosa, you have non-granulomatous inflammation. And what is the drug of choice? The drug of choice in case of the polyarteritis nodosa will be the corticosteroids. So corticosteroids, they are the cornerstone of the treatment. Okay. So this completes the discussion of your polyarteritis nodosa, which is a medium vessel vasculitis. Now, the next important form of vasculitis that you need to know is the Churg-Strauss syndrome. So Churg-Strauss syndrome is what? It is a form of small vessel vasculitis. And what is the type of inflammation that you will come across in small vessel vasculitis? That will be necrotizing inflammation. Right? That will be necrotizing inflammation. And what is the ANCA that will be positive in case of the Churg-Strauss syndrome? That is your P-ANCA. So P-ANCA will be positive in Churg-Strauss syndrome, and even it can be present in microscopic polyangiitis as well. Now, what is the mean age group at which you can have the development of the Churg-Strauss syndrome is around 45 years of age. And if you take male to female ratio, there is slight female preponderance then compared to that of males. That is 1.2:1 is the ratio. Now, if you take the clinical features, now what do you think is the most common clinical features that you come across in patients with Churg-Strauss syndrome? That is arthritis, right? So arthritis, that is the most common clinical manifestation, right? And next is, what is the second most common manifestation in case of Churg-Strauss syndrome? That will be development of mononeuritis multiplex. Right, that is development of mononeuritis multiplex. So these are the most common manifestations and as well as the second most common manifestation. Now, what exactly is your mononeuritis multiplex? This is also called mononeuropathy, right? And it is a type of the peripheral neuropathy. So what exactly happens in mononeuritis multiplex? It happens when there is damage to one, when there is damage to two or more different nerves in the different areas. That is what is called mononeuritis multiplex. Then you should be very much aware of what will be the skin involvement in patients with the Churg-Strauss syndrome. See what exactly is this? It is a form of the small vessel vasculitis. Now, this skin involvement in these patients will be in the form of the purpura, right? This will be in the form of the purpura. That will be the skin involvement. Then the eosinophil levels, if you take up, right? So there will be peripheral eosinophilia. So the eosinophil numbers are elevated. Now, if you take the characteristic laboratory features, first and foremost, there will be striking eosinophilia where the eosinophil cells will be more than 80% compared to that of the normal. Then there will be evidence of inflammation, that is raised ESR, fibrinogen, and as well as alpha 2 globulin. The ANCA will be positive in case of Churg-Strauss syndrome, that is P-ANCA, right? And this particular P-ANCA, so it is formed against what? It is the antibody which is formed against the myeloperoxidase. Okay, so this is about the laboratory manifestations in case of Churg-Strauss syndrome. Now, what do you think is the drug of choice? See, the first line drug in case of Churg-Strauss will be your corticosteroids. That will be the first line treatment. But these corticosteroids alone, they are not given. These corticosteroids should be given along with the azathioprine or methotrexate, right? Along with azathioprine or methotrexate. This has been shown to have a very good efficacy in mild to moderate diseases, whereas you taking moderate to severe form of disease, right? So in moderate to severe form of disease, there you have, mepolizumab, which is an interleukin 5 inhibitor, okay? So this will be the treatment for your Churg-Strauss syndrome. So we are done with the Churg-Strauss. Now, the another important form of vasculitis is Takayasu arteritis. So what exactly is your Takayasu arteritis? That will be the large vessel vasculitis and very commonly seen in age group less than 50 years. And if you take the vascular involvement in Takayasu, remember the most common vessel that will be affected is the left subclavian artery, or the subclavian artery is the one which is most commonly affected in Takayasu. Now, what will be the vascular symptoms in these individuals? Because of the involvement of the left subclavian artery, the blood supply to the left upper limb will be reduced, and thereby the individual will have the absence of pulse in the left upper limb, and that we call it as the pulseless disease. And not only that, there will be also reduced blood pressure in the left upper limb than compared to that of right. So there will be asymmetrical pulse between the two upper limbs, and there will be also asymmetrical blood pressure between the two upper limbs. Now, there are many other conditions where you have unequal blood pressure between the right and as well as left arm. One example is your Takayasu arteritis. Next to your Takayasu arteritis, the other conditions are the coarctation of aorta. But only thing you need to remember, this coarctation should be there preductal. Okay, preductal coarctation of aorta. And the other conditions are obstructive aortoarteritis, supravalvular aortic stenosis, and aortic dissection. So these are the conditions where you can have unequal blood pressure between the two arms. Now, what will be the clinical manifestations? See, because of the involvement of subclavian artery, the blood supply to the upper limb will be reduced, and thereby the patient will present with arm claudication. Right, the patient will present with the arm claudication, right? So whenever the individual start doing some work with the upper limb, he or she will have pain, and after taking rest the pain will disappear, and that is what is called as the arm claudication, right? And the other vessels which can get affected is there can be involvement of common carotid artery, due to which there can be visual changes, there can be even focal attack and cerebrovascular accident, and there can be involvement of abdominal aorta, because of which there will be severe abdominal pain, and there can be involvement of renal artery causing renal artery stenosis, causing the activation of RAS, resulting in hypertension. And vertebral vessels are also affected, and thereby the individual will have, right, thereby the individual will have the posterior column manifestations, because the vertebral vessels are the one which will give the posterior column manifestation, like visual changes can be there and as well as dizziness. So, but the most common vessel which is being affected is the left subclavian artery in case of Takayasu. And you need to be very much aware of what is the most common variant of Takayasu. 1, 2, 3, 4. Can anyone tell me which particular type of Takayasu is more common in India? Right? Which particular type of Takayasu is more common in India? So the type of Takayasu that is more common in India, that will be your type 3. So what does this type 3 constitutes? So type 3, it constitutes both So type 1 and type 2 together we call it as type 3. Now what exactly is your type 1? Type 1 is that where there is involvement of arch of aorta and its branches. So this will be type 1. Then what is your type 2? Type 2 is that where there is involvement of thoracoabdominal aorta and its branches with or without being involved. Okay. So there will be involvement of the thoracoabdominal aorta. That will be your type 2. Whereas you take in type 3, you have the manifestations of 1 and as well as 2. That will be your type 3. That means there is involvement of your arch of aorta and as well as thoracoabdominal aorta as well. And that is what is most common in India. Whereas in type 4, you have the pulmonary artery involvement, and in type 5, you have the involvement of the coronary arteries. Right? So these are the various forms of your Takayasu. But the most common form of Takayasu in India, that will be your type 3. Now, how do you work up these patients? The ESR, definitely it will be elevated. Then whenever you do an iotography, that will show you the presence of the ostial narrowing, and MRI of the aorta is considered as the investigation of choice in patients with the Takayasu arteritis. Then what exactly is the drug of choice? In majority of the forms of vasculitis, the drug of choice will be the steroid, that is prednisolone. And in those individuals who are refractory to steroids, in them you need to give interleukin 6 receptor, that is the tocilizumab, right? That is your tocilizumab. So okay, these are the treatment options that are available for Takayasu, right? Then after having discussed about the Takayasu, the next important form of vasculitis is the giant cell arteritis. So all of the following are true about the temporal arteritis except polymyalgia rheumatica, anemia, low ESR and sudden blindness. Remember, when you are using the word arthritis, the marker of the inflammation should be elevated. So they will not have low ESR, that is, they'll have the high ESR. Then what about the next important question? Most common vessel which is being affected in case of the giant cell arteritis, it is nothing but your temporal arteritis, and thereby the individual will also have the headache. Right, the individual will also have headache, and this particular headache is mostly unilateral, right, mostly unilateral. And there can be also development of visual loss, and the visual loss in case of the Takayasu, that is mainly because of the involvement of posterior ciliary branch of the ophthalmic artery, right? So visual loss, it is due to posterior ciliary branch of ophthalmic artery. Okay, that is one which is responsible for visual blindness. Now what is the inflammatory marker that will decide the development of the visual loss? This is a very important question, and that particular inflammatory marker is the interleukin 6. Then what are the other visual manifestations? The other visual manifestations can be in the form of the diplopia, right? That can be in the form of diplopia. Okay, right. Next is the polymyalgia rheumatica. This polymyalgia rheumatica, it is present in almost 40% of patients with the giant cell arteritis. What exactly is your polymyalgia rheumatica? It is nothing but the stiffness. And where exactly you have the stiffness? That is within the shoulder girdle, right? And as well as the hip girdle. But most commonly it is within the shoulder girdle where you will have the stiffness in polymyalgia rheumatica. And in polymyalgia rheumatica, you need to be very much aware of the investigation of choice. So what is that you need to do is, or in case of giant cell arteritis, you need to do a biopsy. So whenever you do a biopsy, that will show you the presence of the granulomatous inflammation. Then what is the drug of choice in case of your polymyalgia rheumatica or your giant cell arteritis? Remember, the drug of choice here will be the steroids. Right, the drug of choice here will be steroids. So this is about your giant cell arteritis. So in case of giant cell arteritis, you should remember these criteria. Totally 5 criteria are there. Out of this, 3 should be there. Number 1, age of the patient should be more than 50 years. There should be, or it should be, a new onset headache and abnormal temporal artery. That means temporal artery may be containing the granulomatous inflammation. The ESR is being elevated, that is more than 50 millimeters per hour, and the biopsy of the vessel is very important. That is prominent temporal artery biopsy results from vasculitis, which shows granulomatous inflammation, right? Which shows granulomatous inflammation. So out of these 5, at least 3 should be there to call it as the giant cell arteritis. And what is the drug of choice in case of giant cell arteritis? The drug of choice will be the steroids. There is no other alternative drug, right? Now you see the next question. A 32-year-old woman with long-standing diagnosis of long-standing diagnosis of SLE is evaluated by her rheumatologist at a routine follow-up. The new cardiac murmur is heard and echocardiogram is ordered. She feels well and have no fever, weight loss and pre-existing celiac disease. Second day is shown, 2D echo is shown. Which of the following statement is true in this condition? Right. So what exactly is being shown to you here? Right, what has been shown to you is the 2D echo containing the mitral valve, and on the mitral valve you have that hyperdense lesion which is nothing but the vegetations, okay, which is nothing but vegetations. So this particular vegetations in case of the SLE, what do we call it as? That is nothing but your Liebman-Sachs endocarditis, right? Liebman-Sachs endocarditis. So what is the correct statement here? The blood cultures are unlikely to be positive. So definitely, what are these? These are sterile vegetations. So the blood cultures are unlikely to be positive, right? That is the correct statement. And glucocorticoid therapy has been proven? No. For Liebman-Sachs endocarditis, what you need to do is you need to do valvuloplasty, right? That will be the treatment for your Liebman-Sachs endocarditis. Then pericarditis is frequently the presenting concomitant manifestation. No, pericarditis is the most common manifestation of your SLE, but it is not present concomitantly, and the lesion has low risk of embolization is the wrong statement. Even this particular lesions, whenever they rupture, once they enter into the systemic circulation, there is high chance of the embolization in these individuals. Now, what is the diagnostic criteria for SLE? So this is a mnemonic. There are totally 11 criteria. So out of 11 criteria, if 4 are there, then it is very much diagnostic of the SLE, right? And what is that particular 11 criteria? Soap, brain, MD. So the mnemonic that you can remember is, so you wash your brain with soap, then you will get the MD seed. So now what exactly is this soap, brain, MD, right? I'll just tell you one by one. So if the question is being asked, like what is the most common presentation of SLE, then that will be your fatigue, malaise, fever and arthralgia. That is seen in almost 95% of individuals, fatigue and as well as arthralgia along with fever, right? And this, your fatigue, arthralgia and fever is being followed by the next important manifestation, that is hematological and as well as the cutaneous manifestation. Now let me discuss in detail about the SLE. So in SLE, like what is the characteristic acute SLE rash? The characteristic acute SLE rash, that will be the malar rash. That will be malar rash, which is also called as the butterfly rash. And what will be the description of this malar rash? So this malar rash, it is erythematous. It is fixed erythema, flat or raised, and that is present over the malar eminences and as well as the sun exposed part. Now apart from this, you also have the discoid rash, right? You also have the discoid rash, and even your discoid rash, it is also erythematous, circular, raised patch with adherent keratotic scaling, right? So that will be the discoid rash. And the next important skin manifestation can be in the form of photosensitivity. And for the development of photosensitivity, the antibody that you need to know, that is Rho or the SSA antibody, right? So, and these patients, like how do you want the patient to be treated? That is by treatment with the hydroxychloroquine and as well as the sunscreen lotions. And next thing is these ulcers within the oral mucosa, that is the small ulcers which are painless, right? They are superficial small ulcers which are painless, and that will occur over the hard palate, buccal cavity and as well as the vermiform border. Then next is the type of the arthritis. These patients, in case of SLE, the type of arthritis that you will have is non-erosive arthritis. So you see this question here, in which of the following condition or arthritis erosions are not seen? That is non-erosive arthritis. Non-erosive arthritis is seen in patients with the SLE, but not only SLE, two more other conditions where you have non-erosive arthritis is, one is rheumatic fever, then inflammatory bowel disease, then the systemic lupus erythematosus. Now let me take up the discussion of all the organs which are affected in the SLE, right? So there is involvement of the kidney, right? So this particular kidney involvement, okay, what do we describe as, if the question is asked, okay, the kidney involvement, we call it as lupus nephritis. Now the point is, right, the point is the most common lesion in the lupus nephritis, that will be the wire loop lesion. And these wire loop lesions, they are very commonly seen in, these wire loop lesions are very commonly seen in class 4 of lupus nephritis. There are totally 6 classes. In class 4, which is also called diffuse lupus nephritis, you get this particular wire loop lesions. Now, what is the cardiac involvement? The cardiac involvement will be in the form of pancarditis, and among this pancarditis, that is pericarditis, myocarditis, and endocarditis, the most common will be the pericarditis. And what will be the lung involvement? That will be in the form of interstitial lung disease, pleural effusion, and then these individuals will also have the shrinking lung. Right, these individuals will also have shrinking lung. Then what will be the CNS manifestations? The CNS manifestations will be in the form of the seizures and as well as the psychosis. See, the seizures and as well as psychosis is one of the very important area where we need to stress upon. Why? Because you have the antibodies which are responsible for CNS manifestations. What are those? I will discuss. Now, what is the shrinking lung syndrome? Shrinking lung syndrome, that is due to diaphragmatic myopathy. The antibodies are formed against the diaphragm, and thereby there is increase in the dome of the diaphragm, compressing the lung parenchyma, and this we call it as the shrinking lung. Right? This we call it as shrinking lung. Right. Then, what are the psychiatric manifestations? Just now we have discussed that will be in the form of psychosis. Then, hematological manifestation, that can be in the form of pancytopenia. Right, that can be in the form of pancytopenia. Then you take this APLA syndrome, almost 50% of patients are having SLE, they have associated APLA syndrome, and because of which the individual is having the recurrent abortions. That is what is the classical presentation in case of the APLA syndrome. Now, in case of drug induced lupus, so what is the most common drug that will be causing lupus is the procainamide. Right, that will be the procainamide. Okay, so that will be the most common drug that will be causing the drug induced lupus, right? So having said this, yes, you can see the image of the shrinking lung syndrome where you have the diaphragmatic myopathy, due to which the right half of the diaphragm is being paralyzed, right, where the dome of the diaphragm is being elevated. Okay, that is one image. Now, the shrinking lung, it is the characteristic feature of what? It is a characteristic feature of the SL, that is systemic lupus erythematosus, right? Next, then you need to be very much aware of. Yes. So you see this question. Wire loop lesions are often characteristic for following class of the lupus nephritis. So which class is that? That will be your class 4, which is nothing but diffuse proliferative glomerulonephritis. Right? That is where you have this wire loop lesions. Then followed by that, the antibodies. Right? If you take the antibodies, that is a very, very important area in the entire topic of SLE. Which condition, which antibodies will be there? Now, let me take up the discussion of the antibodies. Right. So, if you take the most sensitive marker of the SLE, the most sensitive marker of SLE will be anti-nuclear antibody. Whereas, you take the most specific antibody, the most specific antibody will be anti-Smith antibody. Right. And marker of drug-induced SLE, that will be antihistone antibody. Right, and antibody responsible for thrombus and recurrent abortion, that will be antiphospholipid antibodies. That will be the antiphospholipid antibodies. What are those? I'll discuss that in detail. Now, then coming to psychosis, the antibody which is responsible for the development of the psychosis, that will be anti-ribosomal P. Right, anti-ribosomal P antibody. An antibody which is causing the photosensitivity, just now we have discussed, that is anti-Ro or the SSA antibody. An antibody causing the CNS lupus, that will be the anti-neuronal antibody. Right, anti-neuronal antibody, or we also call it as the anti-glutamate antibody. Okay, so this is the entire story of the antibody picture in case of SLE. Now, at the same time, you need to know the treatment in patients with the SLE. So, what is the drug of choice for acute episodes? Drug of choice for acute episodes will be methylprednisolone. Then you take this, the Liebman-Sachs endocarditis, which is nothing but the valvular involvement. So, whenever there is valvular involvement, that is innermost layer of the heart, there is no role of steroids. So, these patients, they require valvuloplasty. Right? APLA syndrome, you need to give aspirin plus anticoagulant like heparin should be given. Photosensitivity, I said you, hydroxychloroquine is one important drug. And then this application of sunscreen lotions. Then lupus and nephritis with end-stage renal disease. That is where these patients, they require renal transplantation, right? And drug of choice for lupus, severe lupus nephritis, we give cyclophosphamide. And how do you diagnose, or I'm sorry, so for psychosis, what is the treatment that you'll be giving? That is haloperidol, right? That is haloperidol. Then the drug of choice for SLE exacerbation in pregnancy, that will be the hydroxychloroquine. Then in case of the severe lupus cerebritis, that is the point where you need to give dexamethasone. Okay, so this will be the treatment options in case of the systemic lupus erythematosus. Right. So next to this systemic lupus erythematosus, right, let me take up the discussion of the APLA syndrome, that is antiphospholipid antibody syndrome. So antiphospholipid antibody syndrome, the other name which is being given to this is also called as the Hughes syndrome, right? Now, in these patients with antiphospholipid antibody syndrome, three important antibodies are there, and these three important antibodies are the one which are responsible for the development of the hypercoagulability, clot formation. What are those three antibodies? That is the anti-cardiolipin antibody, then anti-beta 2 glycoprotein, then lupus anticoagulant. These are the three antibodies. Now, the presence of which particular antibody is the one which tells you that there is high risk of the pregnancy losses. That is the lupus anticoagulant. So, more is the lupus anticoagulant value, more is the chances of the recurrent abortion. Okay, right. And what is the name of the criteria for your APLA syndrome? That is SAPARO criteria, where you have a clinical criteria and as well as laboratory criteria. Whatever I have taught you is the laboratory criteria, that is three antibodies. Then what is the clinical criteria? There should be vascular thrombosis and then the pregnancy morbidity. So pregnancy morbidity, what is that you need to have? You need to have the recurrent pregnancy loss. That is recurrent abortions should be there. That is, if the individual is like less than 10 weeks, the number of abortions should be more than or equal to 3, right? More than or equal to 3 consecutive abortions at less than 10 weeks. That is one criteria. Or death of the normal fetus more than or equal to 10 weeks. That is another important criteria for pregnancy morbidity. Okay, so and we have one important terminology in case of this APLA syndrome, and that is called as, right, that is called as the Asherman syndrome. What is the, sorry, Asherson syndrome. Asherson syndrome, that tells you it is a catastrophic antiphospholipid antibody syndrome. That is what is called the Asherson syndrome. Then how do you treat these patients with the antiphospholipid antibody syndrome? That is, before, right, before, so what the female has to do is before conceiving, right, she has to be on the aspirin, right? Once the female has conceived, then along with aspirin you need to give the anticoagulant. That is the low molecular weight heparin is being preferred. Okay, so this is about your Hughes syndrome, which is also called APLA syndrome. And remember, in patients who is having SLE, the chance of development of APLA syndrome is almost 50%. But in a normal general population, it is just only 5%. Now, after having discussed about the SLE, the next important is the dermatomyositis and as well as the polymyositis. So dermatomyositis, this is also one of the connective tissue disorder, like where along with skin, right, along with skin, the word derma is skin, along with skin there is also proximal muscle weakness, right? Along with skin there is also proximal muscle weakness. Now in these patients also they have the development of the antibodies, right? And it is also an autoimmune condition. And what are those antibodies? I'll discuss that in detail. And what are the skin manifestations? First of all, the skin manifestations, that includes the heliotrope rash. So what exactly is this? It is a purple blue rash, right, which is distributed over the upper eyelids and as well as the majority of the face, right? And the next important skin manifestation will be the Gottron's papules. Gottron's papules, they are nothing but the erythema of the knuckles, right? Erythema of the knuckles. That is what is your Gottron's papules. And the next important is, like, we have what is called the V sign and the Scholl sign. So you take this particular V sign. What is this V sign? Where you have erythema or erythematous rash which is present over the anterior surface of the chest, and that to upper part of the chest. The next is the Scholl sign. What exactly is the Scholl sign? That is also the same thing. That is erythematous rash exactly being distributed over the shoulders, right? Over the shoulders. Okay. Now, you need to know one of the differential diagnosis of the V sign. And what is the differential diagnosis of the V sign? That is called the necklace sign, which is seen in case of niacin deficiency, that is pellagra. Now, what are the other skin manifestations in dermatomyositis? That includes the periungual telangiectasias, right? Periungual telangiectasias, which is nothing but the dilated capillaries which are present within the finger nails. That is called the telangiectasias. And how will be the hand of these individuals? This we describe it as the mechanic's hand, right? Where you have irregular, distorted skin, and you also have the multiple cracks over the skin of the hand. And not only that, the another important skin manifestation is the deposition of the calcium within the skin, and that we call it as the calcinosis cutis. So these are all the cutaneous manifestations. So I'll quickly recap. So one includes the heliotrope rash, then Gottron's papule, then V sign, Scholl sign, periungual telangiectasia, mechanic's hand, and as well as the calcinosis cutis, right? Now, after having discussed about the skin manifestations, you need to be very much aware of the muscle involvement. So, muscle involvement, what did I tell you? It is the proximal muscle weakness. It is the proximal muscle weakness. And dermatomyositis, what is the age group at which you will have dermatomyositis? It is seen in the childhood, right? It is seen in childhood, or it is also seen in the adults. Okay, also seen in adults. And in case of this dermatomyositis, there is no familial association. There is no familial association, but there can be extramuscular manifestations in dermatomyositis. What is that extramuscular manifestations? That is nothing but your skin involvement. That is nothing but your skin involvement. Okay, right. So this is about your dermatomyositis, and you need to be very much aware of the antibodies. You need to be very much aware of antibodies. But before going on to the antibodies, let me tell you, these patients with dermatomyositis, they are at increased risk of malignancy in adult patients, right? So I said you, it is seen in both adults and children. Dermatomyositis in adults, they are at increased risk of the malignancy. So what is that malignancy that you will see in adults is, that includes the ovarian cancer, lung cancer, pancreatic, stomach, colorectal, and as well as the non-Hodgkin's lymphoma. So these are the malignancies most commonly associated with the dermatomyositis, right? Now you need to be very much aware of the antibodies. Now what is the difference between dermatomyositis and polymyositis? In dermatomyositis you have skin involvement, but whereas in polymyositis there is no skin involvement. It is only the proximal muscle weakness that you will have. Now, what are the antibodies? So, as such, in case of this polymyositis and dermatomyositis, the antibodies which are being present is the anti-Jo1 and as well as the anti-Mi2. In case of polymyositis, you have anti-Jo1, right? Anti-Jo1. Whereas in dermatomyositis, the antibodies which are being present is the anti-Mi2, right? That will be anti-Mi2. And we have one more group of antibodies that is called anti-SRP. This anti-SRP, it is present in both. It is present in both dermatomyositis and as well as the polymyositis. Okay, so these are the antibody profile in case of your polymyositis and dermatomyositis. So definitely, what is the first line treatment? It's an autoimmune disorder. So you need to give the prednisolone, and the dosage is around 40 to 60 milligrams or more is the prednisolone that you need to give. Now, what is the second line agent? The second line agent will be your methotrexate. That means those individuals not tolerating the prednisolone or not responding to prednisolone, in them you need to give methotrexate. And apart from methotrexate, what are the other drugs? That includes azathioprine, cyclophosphamide, chlorambucil, and as well as cyclosporine. But please remember, the second line agent is the methotrexate. Now, in case of the steroid resistant cases of polymyositis, the another important drug is the intravenous immunoglobulin, right? Another important drug is intravenous immunoglobulin. So this completes the discussion of your polymyositis and dermatomyositis. So the important difference is what? In case of polymyositis, only muscle involvement. Dermatomyositis, along with skin involvement, you also have the muscle involvement. And polymyositis, you have to remember that it is mainly seen in children. But whereas dermatomyositis, it is seen both in children and as well as the adults. Okay. And skin manifestations you don't have in case of polymyositis, right? Now after having discussed about, so what all we have discussed now? Vasculitis, SLE, then Apla syndrome. Next, we have discussed polymyositis and dermatomyositis. Now, let me take up the discussion of the ankylosing spondylitis. Now, if you take this ankylosing spondylitis, right? So, in case of ankylosing spondylitis, you have two important articular manifestations. What is the two important articular manifestations? That is the number one, involvement of spine, where there will be fusion of the vertebra. And the next important articular manifestation in case of ankylosing spondylitis is the sacroiliac joint, where there will be sacroiliitis, right? Where there will be sacroiliitis. Now, if you take the spine involvement will be lower down from above, right? So, initially there will be fusion of the vertebra of the sacrum, then lumbar, then thoracic, and then the cervical. So, the sacroiliitis, that is one of the very, very important manifestation in case of the ankylosing spondylitis. And if sacroiliitis is there, if more than or one spondyloarthropathy feature is there, that is more well and good for diagnosis of ankylosing spondylitis. But if HLA-B27 is there, only one spondyloarthropathy feature is not sufficient. You should have more than two spondyloarthropathy features. Now, this HLA-B27 is present in many other conditions apart from the ankylosing spondylitis. Now, can anyone tell me what are the other conditions where you can have HLA-B27 apart from ankylosing spondylitis? Very good. So, you can have that in case of the psoriatic arthritis, then inflammatory bowel disease, then you also have that in case of reactive arthritis. Also, not in rheumatoid arthritis, okay? This is reactive arthritis, right? So, also called Rheumatoid syndrome. So, these are the conditions where you will have the, right? These are the conditions where you will have the HLA-B27 being positive. And if only HLA-B27 is positive, how many spondyloarthropathy features should be there? More than two. Now, what are all those spondyloarthropathy features? You have a mnemonic A, B, C, D, E, F, G, and then IP, right? So, what is this mnemonic you see here? A stands for arthritis, B is your B27, C is your CRP positive, D is dactylitis, E is enthesitis, F is family history of spondyloarthropathies, G stands for good response to NSAIDs, I stands for inflammatory back pain, P stands for the psoriasis. So this is what is your ABCDFGH. Okay. Right. So what are all these? These are all actually spondyloarthropathy features. These are all actually spondyloarthropathy features. And if sacroiliitis is there, more than one spondyloarthropathy feature should be there. But if HLA-B27 is positive, more than or equal to two spondyloarthropathy features should be there. Okay. Now, in these patients with ankylosing spondylitis, apart from joint involvement, that is spine and as well as sacroiliac joint, there are also extra-articular manifestation. Now, what is the most common extra-articular manifestation is the uveitis, that is the anterior uveitis. And cardiac involvement will be there, that is in the form of aortic regurgitation, ischemic heart disease, and third degree AV block. And lung involvement will be there, that is in the form of the upper lobe fibrosis of the lung. And spine involvement will be there, that is in the form of the cauda equina syndrome. GIT involvement in the form of inflammatory bowel disease, and skin involvement will be there, that is in the form of psoriasis. So these are the extra-articular manifestations that you will have in patients with the ankylosing spondylitis. Now, see, how is the vertebra in these individuals? The vertebra is being fused. Now, what is the test that you will be using for assessing the vertebral fusion? Any one of you? So, Schober sign is used to evaluate. Yes, the Schober sign is used to evaluate. So, Schober sign is used to evaluate the flexion of the lumbar spine. Right? We'll not go into the detail of how the test is being done, but this will assess the flexion of the lumbar spine. Now, you see the imaging in patients with ankylosing spondylitis. So when you do an X-ray of the spine, you get this characteristic bamboo spine. And why is that you get this characteristic bamboo spine? That is because of the fusion of the vertebra, and that is because of the calcification of the spinous ligaments. You get this characteristic bamboo-shaped vertebra. Okay. Then next is the dagger sign. Right? Next is the dagger sign. So what exactly is the dagger sign? See, dagger sign in case of ankylosing spondylitis, it is nothing but it is the ossification of supraspinous and as well as the interspinous ligaments. Right? The ossification of the supraspinous and interspinous ligaments. That is what is called as the dagger sign. That is very classical, and many times it has been asked in the previous years. And next important image is the sacroiliac joint. This is a normal sacroiliac joint, but in ankylosing spondylitis, how will be the sacroiliac joint? This is how the sacroiliac joint will be there. That is, there is development of the sacroiliitis. So this is about the manifestations in case of ankylosing spondylitis. So two articular involvement. One is spine, then the other one is sacroiliac joint. Okay, and if there is sacroiliitis, more than or equal to one spondyloarthropathy feature is there. Enough. But for HLA-B27 is there, more than or equal to 2 spondyloarthropathy features should be there, right? Now, what is the treatment? See, the first line treatment in patients with ankylosing spondylitis will be NSAIDs, wherein we give this indomethacin. And those individuals not responding to your NSAIDs, that is NSAID resistant condition, we give this TNF alpha inhibitors. And we have some new drugs which are available for the treatment of ankylosing spondylitis, and these new drugs are the interleukin 17A inhibitors, that includes secukinumab and then the ixekizumab. So these are the two new drugs which are available for the treatment of the ankylosing spondylitis, right? So with this, we are done with the topic of the ankylosing spondylitis, where you have HLA-B27 being positive. Now, the another important connective tissue disorder that we need to quickly recap is about the sarcoidosis, right? It is about the sarcoidosis. Now, can anyone tell me what is the type of inflammation that you will have in case of sarcoidosis? Okay, so the type of inflammation, it will be, right, it will be granulomatous inflammation, and the type of granuloma will be non-caseating granuloma. So what will be the presentation of the patient? So what is the most common organ which is affected in sarcoidosis? This is a multi-system disorder, right? The most common organ which is being affected is lung. And within the lung, what will be the lung involvement? That lung involvement will be in the form of the interstitial lung disease. And very rarely there can be exudative type of pleural effusion. So whenever there is interstitial lung disease, the clinical presentation of the patient to you will be in the form of exertional dyspnea. And they can also have dry cough, right? And the other thing that they'll give you is the investigations are showing that there is hypercalcemia and there is also increase in your ACE levels. So what is your diagnosis there? That is your sarcoidosis. But what exactly is the investigation of choice in case of sarcoidosis? We'll discuss. Now, so what are the pulmonary involvement I have taught you? That is interstitial lung disease, and only in 5% of patients there can be development of exudative type of pleural effusion. And next to your lung involvement, the next important is the involvement of the lymph nodes, and these patients, they will have bilateral hilar lymphadenopathy, and this bilateral hilar lymphadenopathy, it is a hallmark of the sarcoidosis. And along with this hilar lymph node, the other important organ that there can be enlarged is the parotid gland enlargement, and even the parotid gland enlargement in sarcoidosis will be bilateral parotid gland enlargement. Next thing is the skin involvement. So two important skin manifestations. One is your lupus pernio, which is nothing but your purple blues hue around the nose, cheek, lips, and as well as the part of ears. That will be your lupus pernio, right? And the another important skin manifestation will be in the form of the erythema nodosum, right? That will be in the form of erythema nodosum. Now, what are the other systems which are being affected? One is lung, lymph node, skin. The other systems are, there can be involvement of eye also, that is in the form of uveitis. Kidney involvement can be there, that is in the form of renal hypercalcemia. Skeletal involvement will be there, that is in the form of arthritis. Nervous system involvement can be there, that is in the form of peripheral neuropathy. And cardiac involvement can be there, that is in the form of cor pulmonale, right? Now, what is the investigation of choice? The investigation of choice in these individuals will be biopsy. And what does the biopsy shows? The presence of granulomatous inflammation. Presence of granulomatous inflammation. So what does the granuloma contain? The granuloma contain the macrophages and as well as the presence of the giant cells. What are giant cells? They are nothing but the fused macrophages, right? Then next is this, these is a very important sign that you need to know. That is Garland's triad, which is also called as 1, 2, 3 sign, right? Or another name for this is also called as the pawnbroker sign, right? This is also called pawnbroker sign. So what exactly happens here in this? Along with bilateral hilar lymphadenopathy, right? So there will be bilateral hilar lymphadenopathy. Along with that, there is also enlargement of right paratracheal lymph node. There is also enlargement of the right paratracheal lymph node. Okay, so this is what is your Garland's triad. This is what is your Garland's triad. Next, now if you take the gallium uptake studies, so gallium uptake studies, you will have two important signs in sarcoidosis, lambda sign and as well as the panda sign. Now you take this lambda sign. So lambda sign is that where you have gallium uptake within the hilar lymph nodes and as well as paratracheal lymph node, whereas your panda sign is that where the gallium uptake is there within the lacrimal gland and as well as the parotid gland, right? And one more important test, it is only of academic importance. This particular test is not being done now, that is called Queen-Silsback test, right? That is Queen-Silsback test, right? They can just give you as one of the option, which among the following is not the investigation which is not done in sarcoidosis, right? So they may give you some other question option, but Queen-Silsback, that might be one of the option. This is the investigation which is being done for sarcoidosis, but not being used in the present days, because we have many other new investigations which have come up with for sarcoidosis, right? And it's a skin test, right? I'm not going into the detail of the procedure of like how this particular test is being done. Okay, now what is the treatment? See, the drug of choice in these individuals will be steroids. See, the sarcoidosis occurs, the basic pathogenesis is immune hyperreactivity, and you want to suppress that immune hyperreactivity, you can give this corticosteroids, that is the prednisolone. But very much concerning point is in case of the corticosteroid refractory conditions. In corticosteroid refractory disease, the drug which is most commonly used is methotrexate, azathioprine, or the infliximab. These are the three drugs for corticosteroid refractory diseases. Okay, so this is about the completion of the sarcoidosis, which is a multi-system disorder. Now we'll move on to the next important topic, that is the rheumatoid arthritis. Which of the following HLA is specific for the rheumatoid arthritis? Very good. So that is the HLA DR4. What is the condition where you have HLA DR3 and DR4 which is positive? Any one of you? In which condition you have both HLA DR3 and as well as DR4 being positive? That is in type 1 diabetes mellitus. In type 1 diabetes mellitus, you have both HLA DR3 and as well as DR4 being positive. Okay, right. Now we'll move on to a detailed discussion of the rheumatoid arthritis. So rheumatoid arthritis is an autoimmune disease which is more commonly seen in females rather than males. And what is the age group that we see this rheumatoid arthritis? That is around 25 to 55 years of age group. And what are the joints which are commonly affected in these patients with rheumatoid arthritis? The joints which are commonly affected is the small joints, right? And that particular small joints include, that is metacarpophalangeal joints and as well as the proximal interphalangeal joints. Distal interphalangeal joints are not affected in case of rheumatoid arthritis, and the other joints are the involvement of MTP, that is metatarsophalangeal joints. And how is the nature of this disease? It is bilaterally symmetrical disease, right? It is bilaterally symmetrical disease. And what will be this joint manifestations? That is early morning stiffness, and this early morning stiffness will be there for more than 1 hour, right? Early morning stiffness will be there for more than 1 hour, and this stiffness, it decreases as the physical activity of the individual goes on. And this rheumatoid arthritis, depending upon the joint involvement, see, if less than 4 joints are involved, then we call it as monoarticular rheumatoid arthritis. And if more than or equal to 5 joints are affected, then we call it as the polyarticular rheumatoid arthritis. Okay, so now these patients with rheumatoid arthritis in long term, they can develop deformities, and these deformities are swan neck deformity and buttonhole deformity. So swan neck deformity and buttonhole deformity, the joints are exactly opposite in direction. That is, in case of swan neck deformity, right? So in swan neck deformity, there is hyperextension of proximal interphalangeal joint, and there will be flexion of the distal interphalangeal joint. Whereas in buttonhole deformity, it is exactly opposite. There is hyperextension of distal interphalangeal joint and flexion of proximal interphalangeal joint. Okay, so that is what is called buttonhole deformity or the boutonniere's deformity. That is what you will see in case of the rheumatoid arthritis. And what are the other deformities that you will come across? The other deformities are the Z-shaped thumb, right? Z-shaped thumb. And the other deformity can be even the ulnar deviation. So these are the deformities that you will see within the hand, right? That is swan neck deformity, boutonniere's deformity, Z-line deformity, and as well as the ulnar deviation. Next, now, okay, now very important differential diagnosis for your swan neck deformity will be your mallet finger deformity. See, in case of mallet finger deformity, you have only flexion of the distal interphalangeal joint, but the extension of, right, the extension of the PIP will not be there. Extension of PIP will not be there. But in swan neck deformity, what did we discuss? In swan neck deformity, there will be flexion of your DIP and there is hyperextension of the PIP. So PIP, there is hyperextension. There will be flexion of the distal interphalangeal joint in swan neck. But whereas in mallet finger deformity, the PIP will be normal, but there will be flexion of the DIP. Right? And why does this mallet finger deformity occurs? That is due to rupture of the extensor digitorum tendon. That is what is responsible for the flexion of the distal interphalangeal joint. So that is about the joint deformities in rheumatoid arthritis. And what about the spine involvement in rheumatoid arthritis? Even there is also involvement of spine, that is atlantoaxial joint is being affected. Right? That means the part of the spine which is commonly affected in rheumatoid arthritis, that is the cervical spine. And what will be the manifestation of because of the cervical spine involvement? Because of atlantoaxial dislocation, the individual can develop quadriparesis. And what type of quadriparesis is that? You will see in rheumatoid arthritis, it is spastic quadriparesis. Right? It is spastic quadriparesis. That is what you will see. And along with the spastic quadriparesis, these patients, they can also have complications of involvement of brainstem, because this particular dens of axis, the dens of this axis can protrude upwards. Once it protrude upwards, it can cause the compression of the brainstem, where there can be respiratory failure and as well as the vascular collapse as well. Respiratory failure as well as vascular collapse as well. Okay, so that is about the story related to the atlantoaxial joint dislocation. Right? Next, then followed by that, the extra articular involvement. Right? Followed by that, the extra articular involvement. In 40% of patients with rheumatoid arthritis, you have the extra articular involvement, that is multi-system involvement will be there. And among all these particular systems, remember what is the most common extra articular manifestation is the presence of the subcutaneous nodules. Right? The presence of subcutaneous nodules. And these subcutaneous nodules, they are present on the extensor area of your forearm, and they are non-tender. They are non-tender. Now, what would be the cause for mortality in patients with rheumatoid arthritis is, that is because of the cardiac involvement. So what will be that cardiac involvement in case of rheumatoid arthritis? That is, there can be pericarditis, right? And there can be ischemic heart disease, there can be myocarditis, there can be cardiomyopathy, valvular abnormality can be there in the form of mitral regurgitation. And but what would be the cause of death? The cause of death is ischemic heart disease, that is coronary artery disease, would be the cause of death in patients with the rheumatoid arthritis. And what would be the cause for this coronary artery disease? See, your rheumatoid arthritis is an inflammatory condition. So you will have a premature atherosclerosis that would be responsible for the development of coronary artery disease. Then how do you treat these patients? Okay, before going into the treatment of rheumatoid arthritis, you need to remember the two important syndromes of rheumatoid arthritis. That is, you see this question, a 45-year-old coal mine worker presents with cutaneous nodules, joint pain, and occasional cough with dyspnea. Chest radiograph shows multiple small bilateral lung fields, nodules are there, right? Some of the nodules, they show cavitation and specks of calcification as well. Most likely, these features are diagnostic of. The options are Sjogren's, Kaplan's, silicosis, and the Wegener's granulomatosis. So what do you think is the correct answer here? Okay, yeah, Varun Kashyap. See, like how will you differentiate rheumatoid arthritis from osteoarthritis? In case of rheumatoid arthritis, remember, you don't have inflammatory pathology within the distal interphalangeal joint. Distal interphalangeal joint is not affected in case of rheumatoid arthritis. But whereas in case of osteoarthritis, there is involvement of the distal interphalangeal joint, right? And one more point is, your rheumatoid arthritis, it is an inflammatory arthritis, whereas osteoarthritis, it is non-inflammatory arthritis. So how can you definitely diagnose is by synovial fluid examination. Synovial fluid examination in case of rheumatoid arthritis, you can have almost 5,000 to 50,000 cells per cubic millimeter in the synovial fluid analysis. What are those cells? That is the WBCs, inflammatory cells. But whereas here in osteoarthritis, your WBCs are not elevated in the synovial fluid. So this is how you can differentiate rheumatoid arthritis and osteoarthritis. Okay. Yes, Varun, is that clear for you? Okay. Now, after having discussed about the differences, now let me tell you about this syndrome. What exactly is this syndrome? This syndrome is your Kaplan syndrome. What is this Kaplan syndrome? Where you have the rheumatoid arthritis. Along with rheumatoid arthritis, the development of poll workers pneumoconiosis. That is what is called as the Kaplan syndrome. Now, in case of the poll workers pneumoconiosis, what is that you will see within the chest X-ray? In the chest X-ray, you will observe that there is multiple small nodules in bilateral lung fields, right? Multiple small nodules in the bilateral lung fields. That is what you will observe. Okay, that is what is your Kaplan syndrome. One more syndrome you need to be very much aware, that is called Felty's syndrome. Now you see this question. True regarding Felty syndrome is all except which is not included in your Felty syndrome. Splenomegaly, rheumatoid arthritis, neutropenia, and as well as the nephropathy. So which is not included in your Felty syndrome, that will be your nephropathy. So this is a triad that will be there in Felty syndrome. That is a part of your rheumatoid arthritis. Then in rheumatoid arthritis, you should be very much aware of the investigation of choice. The investigation of choice in rheumatoid arthritis, it is not RA factor, it is your anti-CCP. RA factor, it is non-specific, right? RA factor is present in multiple other conditions also, right? So that is the reason why the investigation of choice will be the anti-CCP. And you take this RA factor. This is also an antibody. And what type of antibody is the RA factor? It is an IgM antibody which is directed against Fc portion of the IgG, right? Which is directed against Fc portion of the IgG, right? And the other investigations are the synovial fluid examination. Synovial fluid examination in rheumatoid arthritis will show you that there is 5,000 to 50,000 cells per cubic millimeter. Why? Because it's an inflammatory condition. And next important is the X-ray. Whenever you do an X-ray of the digits, you will notice that there is periarticular erosions or there will be periarticular osteopenia. See, surrounding the joint, you can see that it is blackish in color. That tells you that there is periarticular osteopenia. And not only that, there will be also decrease in the joint space, right? There will be also decrease in the joint space. So there will be joint space loss. Okay, right? And next important investigation is the MRI. The MRI will show you the presence of synovitis or joint effusion or marrow edema. So this is about the the investigations in case of the rheumatoid arthritis. And what is the drug of choice in case of rheumatoid arthritis? The drug of choice in case of rheumatoid arthritis, that will be your methotrexate. And this methotrexate, the dosage is around 5 to 20 milligrams that you have to give once weekly, right? 5 to 20 milligrams once a week. The remaining 6 days, you need to give folinic acid. So like the treatment in case of rheumatoid arthritis in acute phase, right? In acute phase, we give either NSAIDs or steroids, right? NSAIDs or steroids in acute phase. But what is the group of drugs which are given as the disease modifying anti-rheumatic drugs? So we have two groups of drugs, that is non-biologicals and as well as the biological DMARDs. Actually, we need to start with only methotrexate. And if the patient is not responding to methotrexate, then you can step up the dose up to maximum 20 milligrams per week. Or you can give a triple therapy. What is a triple therapy? The triple therapy include methotrexate, then sulfasalazine, then hydroxychloroquine. And even with this triple therapy, if the patient's symptoms are not responding, then you need to start the biological DMARDs. And these biological DMARDs include the TNF alpha inhibitors, the Ankyra, then abatacept, and as well as the rituximab. Okay, so this is about the story related to the rheumatoid arthritis. Okay, and only one thing you need to be very much aware is methotrexate should be given once daily. The remaining 6 days you should give folinic acid. And this prescription should be explained to the patient very clearly. If suppose, like I had a patient, all right, what that patient has interpreted is 6 days she was taking methotrexate, 1 day she was taking folinic acid, right? So exactly ulta interpretation. And she presented with very severe pancytopenia and repeated infection, right? Because your methotrexate can cause bone marrow suppression causing pancytopenia, right? So that is what the presentation of the patient was. So that was about the rheumatoid arthritis. Now, after having discussed about rheumatoid arthritis, let me just do a quick recap of the Behcet syndrome. So all of the following are the features of the Behcet syndrome except recurrent after stomatitis, multi-system involvement seen only in tropics, common in the youngsters. Any one of you? Right. So let me tell you, Behcet's, what is another name for Behcet's? It is also called oro-oculogenital syndrome. And remember, Behcet's is not just seen only in tropics. It is seen both in tropical and as well as the subtropical countries as well. Right? Tropical and as well as subtropical countries as well. And the hallmark manifestation is the recurrent aphthous stomatitis. Multi-system involvement will be there, and it is very common in youngsters of age group around 20 to 30 years, right? Of age group around 20 to 30 years. And what is the another name we have discussed? The another name is the oro-oculogenital syndrome, and the HLA is the HLA-B51 or the HLA-B5, right? HLA-B51 or HLA-B5. And this Behcet syndrome is very common in which country, right? It is very common in Turkey. It is very, very common, most prevalent in Turkey, right? Now, what will be the manifestations we have discussed? That is recurrent aphthous ulcers. That is the hallmark. And these ulcers, you know, they are very painful, right? They are very, very painful. And when I am using the word recurrent, how many times they appear in a year? They appear almost 3 times in 1 year. And whenever they disappear, right, whenever they disappear, there is no scar formation. And your aphthous ulceration, they are the earliest manifestation of the Behcets, right? Earliest manifestation of the Behcets. Okay, and this aphthous ulceration, we consider it as sine qua non for the diagnosis. That means if your recurrent aphthous ulcers is not there, then it is not Behcets at all. And whenever these lesions appear, you will get, or you will have 2 to 5 lesions, right? You will have 2 to 5 lesions per attack. Okay, and the next important is the genital ulcer. Definitely one important is aphthous ulceration, next important is the genital ulceration. And even these genital ulcerations also, they are the recurrent genital ulceration, but here there will be scar formation whenever the ulcer heals, right? And next is the ocular lesions. What are the ocular lesions in Behcets? You have the development of anterior and as well as the posterior uveitis, right? Anterior uveitis and as well as the posterior uveitis. And because of this anterior uveitis or posterior uveitis, the individual can develop blindness. See, because of the anterior uveitis, what is the presentation? Anterior uveitis is associated with a triad. What is a triad? Photophobia, blurred vision and red eye, right? Photophobia, blurred vision and red eye. Whereas posterior uveitis, right, in posterior uveitis, there may be the visual problems where subsequently the individual may go into blindness as well. Okay, so that will be the ocular lesions. Then skin manifestations. See, skin manifestations are in the form of erythema nodosum and as well as the acneiform eruptions, right? Erythema nodosum and acneiform eruptions. Then what will be the CNS involvement in Behcets? The CNS involvement in case of Behcets, that includes the development of meningitis, and here it is the sterile meningitis. And how will be the meningitis? Recurrent meningeal headaches will be there. Recurrent meningeal headaches. So sterile meningitis, and there can be even cranial nerve palsy, and there can be also development of seizures. And GIT involvement will be in the form of aphthous ulceration. Where exactly will be the aphthous ulceration? That will be in the ileum and as well as the cecum. Then vascular involvement. What will be the vascular involvement is there will be involvement of pulmonary artery causing pulmonary artery aneurysm. And if this pulmonary artery aneurysm rupture, there can be development of the pulmonary hemorrhage in these individuals. And there is also involvement of the joints in Behcets, and the joints which are being affected in Behcets, they are, that is the peripheral arthritis, and the joints which are being affected is either it is monoarticular or polyarticular, right? Either single joint or multiple joints are being affected, and this particular joint involvement, it is non-deforming, right? So there is no deformities in this case. And lastly, pulmonary involvement, that will be in the form of pulmonary artery vasculitis. That is what we were discussing. And because of pulmonary artery vasculitis, the patient can present with the chest pain, and not only chest pain, the patient can also have dyspnea, right? The patient can also have dyspnea. So this is the multi-system involvement in Behcets. But what is the most common manifestation? That is recurrent aphthous stomatitis. Okay, then how do you diagnose this Behcets? That is by your pathology test. So the pathology test will be positive. So what exactly is your pathology test? It is phenomenon of developing aseptic nodule or ulcer which is larger than 2 mm in diameter 24 to 48 hours following a sterile needle prick. That is called pathology test, where your pathology test will be positive. Then how do you treat these patients with the Behcets? See, now first is the colchicine, right? So this colchicine and as well as, right, the colchicine and as well as the topical corticosteroids, they will reduce the mucocutaneous finding. That means, right, they will reduce the mucocutaneous finding. That means they will reduce this recurrent after stomatitis. And one more drug, that is apremilast, right? What exactly is your apremilast? It is a selective phosphodiesterase 4 inhibitor, right? Selective phosphodiesterase 4 inhibitor. It is an FDA approved drug for the treatment of oral ulcer in Behcet's. Okay, and when there is severe disease manifestation, that means along with the oral stomatitis, recurrent after ulcers, if there is like multi-system involvement, then we give steroids. Right, then we give steroids. Then coming to your azathioprine, when will you give azathioprine? Is azathioprine, it is effective steroid sparing agent. So for suppose if the individual is developing the features of Cushing's, then we need to stop the steroids, then we need to give azathioprine. And the other drugs are the infliximab, cyclosporin, and then cyclophosphamide. These three drugs are indicated for severe ocular and central nervous system manifestations. So whenever there is ocular and the central nervous system. What is the ocular manifestation? We have discussed anterior and posterior uveitis. What is the central nervous system manifestation? We have discussed, that is the sterile meningitis, cranial nerve palsy, and even seizures. And vascular involvement, we have discussed that vascular involvement will be in the form of the thrombophlebitis. So whenever there is thrombophlebitis, you can give this aspirin. So this aspirin, that is mainly for thrombophlebitis. Now, what are the conditions where we give the oral colchicine? The oral colchicine is given for arthritis. What did I tell you? These patients, they'll have peripheral arthritis. So even for arthritis, we can give this colchicine, right? Whereas the topical, you can give for the mucocutaneous manifestation. So this is about your Behcet's in detail. That is HLA-B51 or HLA-B5, right? Next, then followed by that, let me take up the discussion of the retards or reactive arthritis. All are true regarding retard syndrome except interstitial lung disease, conjunctivitis occurs after sexual exposure, ulcers on the palm, and so. Remember, in patients with retards or reactive arthritis, you don't have the lung involvement. You don't have the lung involvement, and it is characterized by a triad. What is a triad in retards or reactive arthritis? One is asymmetrical arthritis, then urethritis or cervicitis, and then conjunctivitis. Now, you take this arthritis. See, this arthritis, the joints which are commonly affected is, that is mainly the joints of the lower limb. Mainly the joints of the lower limb that is being affected. Along with the arthritis, these patients, they also develop enthesitis. What do you understand by the word enthesitis? It is the inflammation of the tendon at the point of insertion over the bone. Right? Inflammation of the tendon at the point of insertion over the bone. That is what is called as the enthesitis. Right? And this conjunctivitis, right, that is ocular manifestation. Either conjunctivitis can be there, or there can be development of the anterior uveitis as well. And the urogenital manifestation can be in the form of urethritis or cervicitis, and in females there can be even fallopian tube inflammation, that is in the form of salpingitis, or in males even there can be inflammation of the prostate, that is prostatitis. So this will be the urogenital manifestation. And you need to know a few more skin manifestations, that is mucocutaneous manifestation. So number one, there will be oral ulcers. Along with the oral ulcers, these patients, they developed hyperkeratotic lesions. Where will be these hyperkeratotic lesions? That is over the palm and as well as the sole. And that hyperkeratotic lesions, that is called as keratoderma, right? That is called as keratoderma blenorrhegica, right? That is what is your hyperkeratotic lesions, right? Next, and over the glands, there can be also sarcinate balanitis in males, right? There can be inflammation of the glands, and the rare manifestation can be cardiac involvement, and that cardiac involvement will be in the form of the cardiac conduction defects, right? Cardiac conduction defects, or there can be development of the aortic regurgitation, right? So this is about your reactive arthritis. But you have to remember that this Veter syndrome or reactive arthritis, where you have HLA-B27, what is the etiology? They usually occur following the sexually transmitted infection or the gastrointestinal infection. What is the gastrointestinal infection? That will be Shigella, Salmonella, and Campylobacter. The genitourinary infection will be the chlamydia trachomatis. But if the question is asked which is most common in between these two, most common in between these two will be your chlamydia trachomatis, that is sexually transmitted form. That is what is responsible for your retards or reactive arthritis. Then how do you diagnose this retards or reactive arthritis? the diagnosis, it is mainly by the culture, right? Diagnosis is mainly by the culture. So this particular culture, you have to take it from urethra or cervix or even from the throat, okay? And even the cultures of the urine and stool samples, right? The cultures of the urine and the stool samples, they are also helpful for picking out the organism which is responsible. And next is arthrocentesis. Why is that you are doing arthrocentesis? Because these individuals, they are having the involvement of the lower limb joints, right? There is arthritis. So within the lower limb joint synovial fluid analysis, you can have the presence of the inflammatory substances. That means the WBCs can be around 5,000 to 50,000 cells per cubic millimeter. And what is the genetic marker? That will be the HLA-B27. Then how do you treat these patients? See, if there is like urethritis, that is genitourinary lesions are there, you need to give tetracyclines, right? You need to give tetracyclines because the most common organism we are anticipating is Chlamydia trachomatis, for which we give tetracycline. And there is also arthritis, for which we need to give the NSAIDs. And those patients who are refractory to NSAIDs, in them you need to give the immunosuppressant drugs, that is steroids or the sulfasalazine can be given. And whenever there is like iritis or conjunctivitis, then you need to give topical steroids, right? Local steroids means the topical steroids whenever there is iritis or the conjunctivitis. So this is about your reters or the reactive arthritis. So once we are done with the reters or reactive arthritis, then next important topic for the discussion is the Sjogren syndrome. So Sjogren syndrome is associated with all of the following conditions except midline granuloma, chronic active hepatitis, rheumatoid arthritis, then scleroderma, right? So now let me take up the discussion of the Sjogrens. So if you take this Sjogren syndrome, the another name for this is, it is also called keratoconjunctivitis sicca, right? It is also called keratoconjunctivitis sicca, where the individual will have dry eyes and as well as dry mouth. And in these patients with sicca syndrome, it is not only glandular involvement, there is also extraglandular involvement, okay? So there can be chronic active hepatitis, there can be also rheumatoid arthritis, there can be also scleroderma, but this midline granuloma is not seen in case of the sicca syndrome, right? Now let me take up the detailed discussion of the Sjogrens. So what will be the glandular involvement? The involvement of the lacrimal gland and involvement of the salivary gland, okay? So involvement of the lacrimal gland, involvement of the lacrimal gland. So the tear secretion will be reduced. So there will be dry eyes and the individual will have itching and burning sensation within the eyes, and the decreased salivary secretion. So there will be dry mouth. The individual will have difficulty in swallowing. Now very important is, what is that particular viral infection which is associated with the development of your Sjogren syndrome? The viral infection is the HCV infection. Okay, what about your HBV? Just now we have discussed hepatitis B virus. It is associated with which form of vasculitis? Yes, associated with which form of vasculitis? Okay, you answer this. Now if the question is asked like the extraglandular involvement, what is the most common extraglandular involvement? The most common extraglandular involvement will be the arthritis, right? Very good, Monica and Himanshu. It is your polyarteritis nodosa, where you have the association of hepatitis B virus. Okay, so the most common extraglandular involvement will be arthritis. Along with arthritis, the other manifestations that they can have is development of Raynaud's phenomenon, development of renal tubular acidosis, development of vasculitis, and there can be also lymphoma. Now you take primary Sjogrens. Primary Sjogrens means you have only Sjogren syndrome. That means dry eyes, dry mouth, and extraglandular manifestation. Secondary Sjogrens means along with Sjogrens, it is associated with other connective tissue disorders, right? It is associated with other connective tissue disorders. That is called secondary Sjogrens. Now what are the other associated connective tissue disorders? Just now we were discussing, right? That is rheumatoid arthritis. Okay, the other associated connective tissue disorders will be rheumatoid arthritis, or there can be association of systemic lupus erythematosus, or there can be association of scleroderma, or there can be association of the mixed connective tissue disease, or there can be association of the chronic active hepatitis. So these are the other associated connective tissue disorders that we call it as secondary Sjogrens. Now you need to know an important syndrome called Hereford syndrome or uveitis. Remember, your Hereford syndrome or your uveitis is a close differential diagnosis for Sjogren syndrome. And in these patients with Hereford syndrome or uveitis, where do you come across this? You come across this in patients with the sarcoidosis. It is not seen in Sjogren's. It is a feature in sarcoidosis. And even in Hereford syndrome, why am I telling that it is a differential diagnosis for Sjogren's? Because even in your Hereford syndrome, there is parotid and lacrimal gland enlargement, right? But the hallmark feature of sarcoidosis will be bilateral hilar lymphadenopathy, and there will be also seventh cranial nerve palsy in case of your sarcoidosis. Okay, right. But please remember, the differential diagnosis of your sarcoidosis or your Sjogren's will be your Hereford syndrome, right? Why? Because even in this also there is enlargement of your lacrimal and salivary glands. But how will you differentiate this? How will you differentiate is, you take in sarcoidosis, when you do a biopsy, you have the presence of non-caseating granuloma. But in Sjogren's syndrome, like, what is the investigation of choice? That will be the biopsy. When you do the biopsy, you will have the presence of CD4 plus T lymphocytes that will be there in the biopsy of the Sjogren's syndrome. But whereas biopsy of sarcoidosis, you will have non-caseating granuloma. Now, what are the antibodies in Sjogren's? The antibodies in Sjogren's, that will be anti-Rho and as well as the anti-La. These are the antibodies in Sjogren's, right? Now, what will happen to the salivary secretion in Sjogren's? The salivary secretion in Sjogren's will be reduced. But you need to be very much aware of what is a normal salivary secretion. Normal salivary secretion, it is around 1 to 2 ml per minute, right? 1 to 2 ml per minute. Okay. But in Sjogren's, what will happen? In Sjogren's, the unstimulated whole salivary secretion will be less than 1.5 ml per 15 minutes. In 15 minutes, the amount of saliva that is being secreted in Sjogren's will be less than 1.5 ml. So that is a very, very important point that you need to remember. And next thing is the Schimmer's test. Why is that we do this Schimmer's test? That is mainly to assess the lacrimal secretion, right? That is mainly to assess the lacrimal secretion. Now, this Schimmer's test is being done by placing a strip. And if, how much will be the normal tear production? The normal tear production will be up to 20 mm. That will be up to 20 mm for 5 minutes, right? You keep that strip for 5 minutes. The strip will get blotted up to 20 mm. But when will you call it as insufficient or Sjogren's? That will be when the secretions are less than 5 mm. Right? On the strip, if the secretion is less than 5 mm in 5 minutes, then we consider it to be suggestive of the Sjogren's. Okay, right. Then how do you treat these patients with the Sjogren's? See, the basic point is the abnormality in the tear secretion. There is decrease in tear secretion. So thereby there is dry eyes. So these patients, you have to give artificial tears. Right? You have to give the artificial tears. Okay, right. And next thing is cyclosporin. See, what is the purpose of giving this cyclosporin is, cyclosporin, it will suppress the inflammation. Cyclosporin, it will suppress the inflammation within the lacrimal gland, and thereby it can increase the tear secretion, right? Next, these individuals, what did I tell you? Most common extraglandular manifestation will be arthritis. So for arthritis, what is that we give is non-steroidal anti-inflammatory drug, right? Non-steroidal anti-inflammatory drug. But for individuals with severe complications, like multiple extraglandular manifestations are there, when there is multiple extraglandular involvement, that is the point when you need to give the immunosuppressive drugs, right? And these particular immunosuppressive drugs, that includes the corticosteroids, right? That is systemic corticosteroids, or sometimes even intravenous immunoglobulins are also given, right? So this is about in toto of the Sjogren's syndrome. In toto of the Sjogren's syndrome. Now, once we are done with the Sjogren's, the next important topic in the connective tissue disorder will be the scleroderma, right? The next important topic will be the scleroderma. So this scleroderma, if you see, we have two forms. One is localized scleroderma and the other one is diffuse scleroderma. So in localized scleroderma, what is the important point that you have to remember is there will be limited skin involvement, and the skin involvement will be there mostly confined to the fingers, then forearm, then face, and even that skin involvement also will be a very slow progression, right? Very slow progression, and the visceral organ involvement in localized scleroderma, it will be very late, right? It will be very late. And some patients with limited scleroderma, they develop what is called the CREST syndrome. What is this? C stands for, that is calcinosis, right? CREST in C stands for calcinosis. where there is subcutaneous calcification of the fingers and subcutaneous calcification along the extensor surface of the forearm. And R stands for the Raynaud's phenomenon, right? E stands for the esophageal dysmotility, right? E stands for the esophageal dysmotility, right? And next S stands for sclerodactyly, right? Sclerodactyly, where the skin thickening is limited to the fingers. There is thickening of the skin within the fingers. And T stands for telangiectasia. What is telangiectasia? That is nothing but your dilated capillaries. That is what is your telangiectasia, right? And you need to be very much aware of there are certain drugs which can cause this scleroderma. And what are these particular drugs which can cause the scleroderma? These drugs include like bleomycin and all can cause this scleroderma. Then what about this diffuse scleroderma? See, diffuse scleroderma is that where the skin involvement is rapid, widespread skin involvement will be there, right? Along with the widespread skin involvement, these individuals, they will have rapid progression of the visceral organ involvement, right? Rapid progression of the visceral organ involvement. That is what is your diffuse scleroderma manifestation. Now, one important point is what are all the organs which are affected in diffuse scleroderma? So, number one, definitely yes, the skin will be involved, and you can see how the skin will be there. So, like the individual will not be able to open the mouth because of the tightness of the skin, and that we call it as the microstomia. And you can see the digits, right? So, the digital infarcts you can see in these patients with the scleroderma. Now, that will be the skin involvement. So there will be skin thickening. Skin thickening is the most recognizable manifestation of the scleroderma. And this skin involvement mainly it starts within the digits, that too distal, and then it will progress proximally. And the next important manifestation is the Raynaud's phenomenon. Right now, in Raynaud's phenomenon, the color changes are very, very important. Right, the color changes are very, very important. So initially, when the individual is exposed to the cold environment, there will be pallor. Then there will be development of cyanosis. Then there will be erythema, red color. So pale, blue and red. Then what will be the GIT manifestation? So the abnormal collagen gets accumulated even within the esophagus. So once there is accumulation of the abnormal collagen within the lower esophageal sphincter, the patient will have dysphagia. So there will be difficulty in swallowing, and there will be also reflux. There will be development of gastroesophageal reflux disease. And not only that, see, the abnormal collagen gets accumulated even within the intestinal wall and as well as stomach also. So gastrointestinal emptying will be delayed, and because the abnormal collagen is accumulated within the intestine, absorption of the nutrients will not be there across the intestine. So the nutrients will stay within the intestine, and that particular nutrients will get fermented by the intestinal bacteria. So there will be excessive gases which are being produced within the intestine, and that we call it as pneumatosis, right? That we call it as pneumatosis intestinalis. Pneumatosis intestinalis. Then followed by that, the musculoskeletal system involvement. So musculoskeletal system involvement will be in the form of symmetrical arthritis, right? That will be in the form of the symmetrical arthritis. That will be the musculoskeletal system involvement. And what will be the kidney involvement? The kidney involvement or the renal involvement will be in the form of renal artery stenosis due to abnormal collagen accumulation within the renal artery, and there will be activation of RAS resulting in the hypertensive crisis. And lung involvement will be in the form of the interstitial fibrosis, that is due to accumulation of the collagen. And what will be the cardiac involvement? The cardiac involvement will be in the form of the pericardial effusion and as well as the myocardial fibrosis, right? Myocardial fibrosis. Now, what do you think is the cause of death in these patients? See, the cause of, and one more, yeah, cardiac involvement. The other thing that you should remember is the development of cardiomyopathy. That is development of restrictive cardiomyopathy. And because of the development of restrictive cardiomyopathy, these patients, they can have Kussmaul sign, all other features can be there. Now, the point is, what is the cause of death in these patients with the scleroderma? So, the cause of death in these patients with scleroderma, very, very important, that is development of the pulmonary artery hypertension. And because of the pulmonary artery hypertension, there can be right heart failure, there can be development of the cor pulmonale, and finally death of the individual. So the cause of death in these individuals would be the development of the pulmonary hypertension. Now, what do you think is the drug of choice in patients with the scleroderma? The drug of choice in patients with scleroderma, again scleroderma, it is what? It is an autoimmune condition. See, in case of localized scleroderma, the antibody is the anti-centromere antibody, and in case of diffuse scleroderma, the antibody is the anti-topoisomerase antibody. Right? Now we don't want this antibody production. So what do you think is the drug of choice? The drug of choice will be the steroids. That is prednisolone. And these patients, because of your lower esophageal sphincter stenosis, they are developing gastroesophageal reflux. So for which you can give the proton pump inhibitors. And there is delayed gastric emptying because of the accumulation of the collagen within the stomach. So you need to give a prokinetic agent. And that prokinetic agent, that is your metoclopramide, which can increase the gastric emptying, or the cisapride or mozapride. So that will be the drugs for increasing the gastric emptying. Next is the hypertensive crisis. Now, how do you handle this hypertensive crisis due to renal artery stenosis? In this particular scenario, whenever there is hypertensive crisis, that we call it as scleroderma renal crisis. And in scleroderma renal crisis, the drug that we give is the ACE inhibitors. Right, the drug that we give is the ACE inhibitors. Okay, right, and the other alternative drugs will be your calcium channel blocker, that is nicardipine, and all can be given. Right, previously we were giving nitroprusside, but these days your sodium nitroprusside is not being used because of the cyanide toxicity and all. Okay, so this is about the manifestations in scleroderma. And one more important point in scleroderma that you need to be very much aware is, what is the cause of death? Pulmonary hypertension. So what are the drugs that you need to give for treating this pulmonary hypertension? You need to give endothelin receptor antagonist, that is bosentan, and the alternative drugs are the phosphodiesterase 5 inhibitors, that is sildenafil, tadalafil, or vardenafil, or your CGP, that is guanylate cyclase stimulant, that is rosigot, and endothelin 1 receptor antagonist, that is bosentan or macitentan. These are the drugs which will definitely be given as a first line for the pulmonary hypertension in case of the scleroderma. But only concern is whenever there is refractory pulmonary hypertension. See, whenever there is refractory pulmonary hypertension, in them you need to give the prostacyclin analogs. And these prostacyclin analogs, they are epoprostenol, treprostinil, and as well as the iloprost. So these are the drugs which are given for treatment of pulmonary hypertension. So which type of patients with scleroderma they can have this mortality? That is only diffuse scleroderma, not the localized scleroderma. Why? Because in diffuse scleroderma you have rapid visceral organ involvement. Even there can be development of pulmonary hypertension that can cause the death of the individual. And this is what is your treatment. So the first line drugs that you can give is endothelin receptor antagonists. The alternative drugs are phosphodiesterase type 5 inhibitors, that is sildenafil, tadalafil, and as well as vardenafil. The new drugs are guanylate cyclase stimulant, that is riociguat, right? And we have the refractory condition, we give prostacyclin analogs, that will be epoprostenol, treprostinil, and as well as the iloprost. So we are done with the scleroderma. And one last topic for the discussion will be, yes, okay, you are seeing Mr. Hensley, a 72-year-old man with only a history of hypertension on hydrochlorothiazide. He presents today with acute excruciating knee pain. On examination, his knee is warm, mildly erythematous, swollen, and tender to touch or passive movement. Microscopic examination of the joint fluid is shown in the figure. What is Mr. Hensley most likely? Metabolic derangement, acute bacterial joint infection, antibodies to anti-nuclear antigen, hyaline cartilage degeneration, increased production of inorganic pyrophosphate, uric acid overproduction. Right. So which particular joint is affected? That is knee joint. Okay. And what are all the problems? He is a 72-year male. He is taking thiazide diuretic, and this is the synovial fluid analysis. Right. This is the synovial fluid analysis. Right. So the correct answer here is the uric acid overproduction. So what exactly is this suggestive of? This is suggestive of your gout or the gouty arthritis. Why is that you are considering gout or gouty arthritis even though the knee joint is involved? Actually, in gout, what is the joint which is being affected? That is the involvement of the first metatarsophalangeal joint. The next most common joint which can be affected is the knee joint. Right, the knee joint. And what are the risk factors in this patient to consider it as gout or gouty arthritis? First important risk factor is he is a male. That is one thing. Second important risk factor is the patient is having hypertension. And third important risk factor is the patient is taking thiazides. These thiazides, they increase the uric acid production. And why? How is that you are telling it is a gout? The synovial fluid analysis, right? The synovial fluid analysis, you are seeing the negatively birefringent needle-shaped crystals, right? Negatively birefringent needle-shaped crystals, right? So, which is suggestive of your gout or the gouty arthritis. And please remember, in your gout or gouty arthritis, the serum uric acid, right? The serum uric acid, it may be normal also, right? It may be normal also. When can you have the serum uric acid being normal? That is, in acute forms of gouty arthritis, the urate which is present within the serum, it will go and accumulate within the joint in the form of urate crystals. That is monosodium urate crystals within the joint. So when the entire urate has gone into the joint, the uric acid levels within the serum or plasma may be normal. So that is the reason why serum uric acid itself we don't take as the diagnostic test. The investigation of choice will be synovial fluid analysis, which will show you negatively birefringent monosodium urate crystals. Understood? And the serum uric acid levels, they are mainly used as the monitoring, the treatment, right? Monitoring the treatment. Okay, right. Now let me take up the discussion of like how do you treat these patients. So you see here, you're planning to start allopurinol for Miss Maggie for a new diagnosis of gouty arthritis. Which of the following best describes appropriate dosing strategies for the allopurinol? You go through all the options. Allopurinol and azathioprine are commonly used together in treatment of gout. Allopurinol dosing should be adjusted for liver function. Third option, allopurinol dosing should be titrated to achieve the serum uric acid levels of less than 6. Fourth option, allopurinol should be avoided when patients are taking colchicine. Allopurinol toxicity is more common in patients expressing the HLA-B27. So what do you think is the correct statement here? Okay, so what exactly are the treatment for your gout or gouty arthritis? You need to give uricosuric agents that will increase, right? That will increase the uric acid excretion, and then you need to decrease the uric acid synthesis. Yes, any one of you? No, it is not D here, right? So what are the uricosuric agents? The uricosuric agents that includes rasburicase and as well as the probenecid. And what are the drugs which will decrease the uric acid synthesis? They are basically xanthine oxidase inhibitors. And these xanthine oxidase inhibitors are allopurinol is one particular drug and the other one is febuxostat. These two are your xanthine oxidase inhibitors. All right. Now coming to this particular dosing. So the allopurinol, if you see, it can be given as a single morning dose. That is 100 milligrams is the initial dose that we start with. 100 milligrams initially we start with. And how much of allopurinol you can increase up to? You can increase up to 800 milligrams. And remember, not in patients with liver function, you require the dosing adjustment. You require the dosing adjustment in patients with the chronic renal failure. In patients with chronic renal failure, they require the dosing adjustment. It is not the liver disease patients, right? And whenever you are giving allopurinol, what should be your target value of your urate? The target value of your urate should be less than 6 milligrams per deciliter. Okay, now if you take the toxicity of allopurinol has been recognized increasingly in patients who use thiazide diuretics, right? Not so allopurinol should be avoided when patients are taking allopurinol. No problem. Colchicine can be given in acute form. In acute gouty arthritis, we give colchicine, right? We give colchicine, and along with this colchicine, you can add allopurinol. But only thing is, along with the allopurinol, you cannot add thiazide diuretics. You cannot add penicillins. You cannot add the ampicillin. Okay, and allopurinol toxicity is more common in patients expressing HLA-B27 is a wrong statement, right? Now, in which group of individuals where the allopurinol toxicity can be there is that is in patients who have the HLA B5801. These patients, if they take allopurinol, there is increased risk of the allopurinol toxicity, right? And this colchicine is commonly used along with the allopurinol in the treatment of your gout or gouty arthritis. And even your allopurinol and as well as azathioprine are commonly used together in the treatment of gout. Let me tell you, allopurinol and azathioprine should not be co-prescribed. Why? Because azathioprine can increase the blood levels of allopurinol, leading to toxicity. That is the reason why both of these drugs should not be used together. Okay, so this is about the story related to your gout or gouty arthritis. So with this, yeah, Himanshu, I'll teach you the pseudo gout as well. So if you take this pseudo gout, in pseudo gout, the joint which is commonly affected is the knee joint, right? And the crystals which are being accumulated in pseudogout will be calcium pyrophosphate crystals, that is CPPD crystals, and these crystals, they are positively birefringent, right? These crystals, they are positively birefringent, and the drug of choice will be the NSAIDs. That is what is your pseudogout. Okay, so this completes the discussion of your the entire connective tissue disorders. Okay, so what all topics we have completely revised? So we are done and dusted with the all these topics, right? That is vasculitis, SLE, rheumatoid arthritis, ankylosing spondylitis, Behcet's, reactive arthritis, sarcoidosis, gout, scleroderma, apla, and Sjogren syndrome. Right? We are done with all the connective tissue disorders.